Hello, I'm Dr. Anil Koti. I'm a consultant in reproductive medicine surgery and assisted conception at the Homerton Fertility Centre in London. So today I'm going to talk to you about generally a GnRH analog or a GnRH agonist, whatever you call it, the trigger. And this was a paper published recently in Human Reproduction. And what it was looking at does the dose of the GnRH analog make any difference to the quality of oocyte, which means is the maturity of oocytes that are obtained. And thus, that is something which we have always debated on, and what is the exact dose of the GnRH analog trigger when you use it to trigger ovulation. So where does this all start? And it all starts because IVF carries a high risk of ovarian hyperstimulation syndrome, which at times can be disastrous. So if you look at the overall picture, between 10 and 38% of ovarian hyperstimulation, the vascular endothelial factor is HCG driven, and that initiates the cycle of causing ovarian hyperstimulation syndrome. It increases vascular permeability and causes fluid shift. The GnRH agonists are far more efficient in preventing ovarian hyperstimulation syndrome, and I'll say almost, get the incidence down to less than 1%. It also induces luteolysis of the corpus luteum, and thus it tends to have a much shorter luteal phase. So which are the agonists that we use? And it's important to realize that in every country they'll use a different agonist. So you got triptorelin, which is used at 0.2 milligram, biserelin, which is used in the United Kingdom at 0.2, 0.5 or 1 milligram, leuprolide acetate, which is used at 0.5 milligram, 1 milligram or 1.5 milligram, neferelin, which is used at 400 microgram, which is the nasal spray, and intranasal biserelin, which is 0.2 milligram. Across the world, triptorelin seems to be commonly used, and mainly I think that is in Europe. So if you have a look at the protocol was 131 patients using recombinant FSH and a flexible antagonist protocol. So what's the difference between a fixed protocol? Fixed antagonist protocol is starting on day 4 or day 5 or day 6 as you wish. And a flexible is when the follicle size reaches probably about a size 14 millimeter. The trigger was given when follicle size reached 17 millimeter and above, and egg collection was done 35 to 36 hours later. So, and how were the results looked at? Now, there are two new definitions which we have to go through, and one of them is called the oocyte maturation rate. And how is the oocyte maturation rate calculated? It is calculated from the total number of metaphase 2 oocytes, and in effect, very simply, the total number of eggs or total number of cumulus oocyte complex. And oocyte recovery rate is total number of cumulus oocyte complex divided by follicles which are greater than 11 millimeter on the day of trigger. Fertilization rate is defined as the number of 2PN embryos divided by the number of metaphase 2 oocytes. And then we looked at the duration of the luteal phase. And here it's interesting. So when you looked at oocyte maturation rate, there was no difference in the dose of either 0.1, 0.2 or 0.4 milligram. And then if you look at metaphase 2 oocytes, very similar. 2PN, 2 pronuclear, and that was very similar. Fertilization rates were very much similar, and duration of luteal phase, again interrupted, shorter, was very much similar. If you again looked at the hormonal profile, the progesterone was highest on day 3 and not later on, and then it starts dropping. The FSH, LH rise were very similar 8 hours after the trigger was given. And again, you don't measure the LH, I'll say, 24 hours or 48 hours later, in fact, it has disappeared by then. Why? Because the analog trigger or the agonist trigger's rise of LH is usually the peak of 4 hours, and I think within 24 hours, LH disappears, unlike the normal LH, which stays there for 48 hours. So what does this paper tell us, and why is it important? It's important because we don't have a dose-finding study, and we really do not know what is the exact dose of GnRH analog trigger. So what do we think? And we think that irrespective of the dose given of that, of 0.1, 0.2 or greater than 0.4, the mature eggs, the fertilization rate, the cumulus oocyte complex, and the empty oocytes were similar. There was a simultaneous rise of FSH, LH and peaking after 8 hours of the trigger. Progesterone was highest in all the 3 cases on day 3. There were no cases of ovarian hyperstimulation syndrome. There was a shorter luteal phase, and there was no difference in the dose of GnRH analog. Now, why is this important? It's important because you go to various meetings and we will always tell you this is the dose I use. And none of us are really wrong in that, because we use our personal experience, and I tend to give a higher dose of analog. And I think there's a reason for that, and there has been a paper which looked at ethnic origins and how the GnRH analog trigger worked, and it seems to vary in some ethnic groups. And this was done by, I believe, up in Denmark, a very good group which had done it. But also what I want to convince people is it's important that you make IVF safer. And how do you make it safer? You make it safer by moving away from the long protocol. And where does long protocol really work? I would say it seems to work reasonably well in normal responders, but it doesn't seem to work very well in poor responders and hyper responders. And unless you're very certain that your patient is not going to overstimulate, where in spite of not having PCOS and having ovaries that have a good antral follicle count, and you can be certain she does not go into ovarian hyperstimulation syndrome, I think you should work with the antagonist protocol and use an analog trigger. The agonist trigger or the analog trigger, in fact, reduces your chances of having ovarian hyperstimulation syndrome, and with freezing of embryos, success rates are significantly better. And so the more you move towards the antagonist protocol and convert a large proportion of your cases, and you can do that even when batching, you will see that you'll be able to work with different triggers, and you'll be able to work with single triggers. You can work with dual or double triggers, and all these give us a completely different, fascinating facet into how IVF is changing. So thank you very much, and if you do like this video, please like it and share it, and we look towards seeing you again in the future. Thank you.